Good evening, everybody. I welcome you all to this session, this webinar on a very important topic, investigations on dialysis. This is being organized by NephroPlus along with Kidney Warriors Foundation. And I'd like to thank Kidney Warriors Foundation for doing this series of webinars in association with NephroPlus on several important topics related to dialysis and other kidney diseases. Today we have with us Dr. Arvind Canchi, a very senior nephrologist based out of Bangalore and a prolific Twitter personality in the field of nephrology. Dr. Canchi does a stellar job in sharing some very useful research and other aspects on nephrology. He has a wide following on Twitter among nephrology and non-nephrology circles. And I thank you, Dr. Canchi, for taking out time and participating in this webinar.
Thank you.
Without further ado, my name is Kamal Disha. I'm the co-founder of NephroPlus. I'm a dialysis patient for the last 25 years almost. And I am very proud to be hosting this webinar and interviewing Dr. Canchi and getting his thoughts on this extremely important topic that is investigations on dialysis. So I started off, Dr. Canchi. A lot of we patients, me included, have this question in our minds that why do we need any investigations at all? I mean, what exactly do doctors want additional information apart from the fact that we are getting dialysis? What additional information does investigations basically give doctors like yourself in helping us with our kidney disease journey?
Thank you, Kamal. I need to thank Mr. Kamal Shah as well as Vasundhara for inviting me to this program. So nice of Vasundhara Raghavan to call me and ask me to participate. Now, as far as investigations go, and I'm going to put up some slides in a moment, as far as investigations go, basically you're looking at a dialysis patient needing dialysis because the patient has kidney failure. Now, when we start a particular treatment, we are now looking at the patient to decide, is this treatment affecting the patient favorably? Is the patient getting better? Is the patient responding to treatment? Are there problems with the treatment? What are the drawbacks that are happening with the treatment? The treatment basically being dialysis. So in such a situation, we have to fall back on two things. One is clinical judgment, assessment of the patient, looking at how the patient is doing. For example, what's his blood pressure? What's his weight? Is he putting on a lot of swelling in his legs? Is he becoming breathless? Is his vomiting getting better? Is his taste for food getting better? And these are all symptoms and signs that we look for in dialysis patients when they come in to start dialysis. On the other hand, you also need investigations. You need tests to make sure that the dialysis that is going on is effective. Is it removing the right toxins? Is it therefore the patient? Now we have to remember, in a dialysis patient, there are so many things that go wrong. The patient can have a heart problem on one side. The patient can have anemia or low blood strength on the other side. All of this related to kidney failure. The patient can have bone problems, what we call renal osteodystrophy. The patient can have acid levels increased in the body. The patient can have abnormal sodium and potassium levels, which we call as electrolytes. And the tendency is for the potassium level to go up and affect the heart. So these are numbers that we therefore tend to look at in our patients. So I'm going to share the screen in a bit right now, if I can, and move on to show you what we do. So basically, this is to look at several things in the patient, and this is something that I already talked about. Back to you, Kamal.
Yeah. Thank you, Dr. Canchi. That's very helpful. Now, in a country like India, Dr. Canchi, I'm sure you're fully aware and you're probably encountering this problem in your day-to-day practice. For dialysis patients, dialysis expense itself is huge. I mean, very few people can actually afford out of pocket, the expense on the dialysis treatment. Now, apart from this, if we need to do blood tests, like what is the bare minimum blood test that without which you would say that patients are actually risking their treatment, risking their life? what are the bare minimum blood tests without which you would say that no, this is absolutely not done? The bare minimum, like monthly, if we can just say, like every month, what would you absolutely insist on?
So that's a great question to ask. And actually, we've looked at our own data, and many have, looking at dialysis patients in India. We found that about 55% of patients have some form of insurance, company cover, uh, through which they can actually pay for dialysis. Some of the insurance does not cover outpatient investigations. So it's a bit of a problem there. And 45% of our dialysis patients in the population that we studied were paying out of their pocket. So obviously it is a problem when you're looking at the need for investigations in dialysis, and that leading to an added cost for most of these patients. So you're looking at a bare minimum. I would look at some of these tests that I'm putting up. Now, the question of whether you should do this once a month or whether you can get away with doing it once in 6 weeks to 8 weeks has also been addressed in a trial, and I'm going to show you some data on that. But first, hemoglobin level, serum creatinine and blood urea, sodium, potassium, and albumin level, which may well be done once in 2 months or 3 months, a sugar level for diabetics, a bicarbonate level for those to test out the acid removal. Calcium phosphate, again, is something, and LFT is something that you can do once in 2 or 3 months. You may not want to do it once a month. So if you're looking at the basic tests, then I would go with the hemoglobin, creatinine, urea, sodium, potassium. These are the things, the top 4 that I put up there is what I would look at as a basic minimum. And that would cost you about, let us say, 300 to 350 rupees, which is something that, it's something that I would definitely want in my patients. On the other hand, it shouldn't be very costly. So there are various renal packages that go up to 2,000, 3,000 rupees. You may want to sort of sort out as a nephrologist, looking at your patient load, looking at where your patients are coming from. You may want to sort out that load and decide, look, this is the basic minimum, but that I want you to do every month. But there are other tests that I may want you to do every 2 months or 3 months. And obviously, the urea reduction ratio, or the K2OV, which I've marked in red at the bottom of the screen, this is something that we will want to look at, because we need to know the efficacy of dialysis. We need to know the efficacy of toxin removal on dialysis. And if you're looking at urea reduction ratio, which is basically the removal of urea, you would want to do a urea level at the time you start dialysis, maybe a creatinine as well, and you'd want to do a urea level at the end of dialysis, preferably half an hour after the end of dialysis, because you would want if you're looking at the two-pool system, you would want equilibration of urea to occur in the blood before you actually draw out the sample. And in such a situation, the urea reduction ratio of about 65%, right up to 70% would be great, which means that the access is working well, your dialyzer is working well, the machine is working well, and it's removing enough toxins. K2OV is another thing that we look at. We look at a number of 1.2. I'm not going to go into the details of this, all available on the net, and a bit too sciencey for the patient. So I'm not going to look at that in great detail. But if you're looking at once a month, let me just point out to you, to the folks who are watching, that you are going to do all these tests because you are looking at various systems in the body that are affected by kidney failure, and you're looking at how those systems are going to be improved. So if you're looking at dialysis treatment, K2OV and URR, or urea reduction ratio, measures how the dialysis treatment is effective in removing solutes and toxins. You're looking at hemoglobin to look at the heart health. You're looking at potassium to look at the heart health, as well as nutrition. You're looking at albumin, which is quite an important number, and we'll come to that in a moment. You're looking at nutrition. You're looking at phosphorus again, parathyroid hormone, calciums to look at heart health and bone health. So there are various sort of systems that are involved in kidney failure, and all of these need improvement. And these are numbers that will point to all of that. And I'm going to quickly show you something about this question of whether we should do it once a month. And this was actually addressed in a trial in the US. And they looked at, obviously they have all the data going for them because they have a huge sort of data bank from which they glean out all this data. And they looked at looking at 4 weeks versus 6 weeks blood sampling, routine blood sampling. And is the frequency good? Should we keep this frequency of 4 weeks, and can we go to 6 weeks is what they looked at. And they found that 6 weeks is as good as 4 weeks. And this is one of those sort of visual abstracts that tell you that there was no difference between 4 week sampling versus 6 week sampling when they were looking at mortality, hemoglobin target, phosphate targets, among other things. But they did find that there was a huge amount of savings, roughly about $25,000. This is obviously to the hospital and insurance. But if you look at it from the patient perspective in India, then that is a saving to the patient as well. So there is really, and that is the answer, is routine monthly blood draws in dialysis needed? Well, perhaps, but you can get away with 6 weeks or maybe 8 weeks. So that's something that is should be at the back of the nephrologist's mind. If there are patients who are unwilling to pay purely on a financial aspect, you may want to consider going to a 6-weekly sort of look at those investigations.
Sure. No, that's very helpful, Dr. Canchi. And while this is a study done in North America, I think there are some lessons to be learned by us as well. Though here the conditions are very different, where a large majority of patients get only twice a week dialysis. I just wanted to take you back to the slide where you listed the investigation. We just talk a little bit about, for example, hemoglobin, right? What happens if somebody doesn't test their hemoglobin, and if it goes too low, right? What are the risks that a patient can have? Because some people, honestly, they have to prioritize dialysis over, over hemoglobin testing, for example. Like, I understand it's only one test, but if you can just talk a little bit about the importance of hemoglobin, because that's one test that almost every doctor tells us that you have to get your hemoglobin tested. So if you can just talk a little bit about hemoglobin.
So as far as hemoglobin goes, this is one of the most important tests that we tend to do on a monthly basis, or let's say once in 6 weeks. This is because CKD patients or patients with chronic kidney disease develop anemia, and they develop anemia because erythropoietin that is secreted from the tubule the kidneys no longer secrete this important hormone called erythropoietin. And as a result, patients who have chronic kidney disease end up having anemia. Not only that, towards the latter stages of their CKD, especially when they're in CKD stage 5, they do develop problems with nutritional issues, appetite, and vomiting, nausea, and tend to have less food, those building blocks that help the bone marrow in forming hemoglobin. And therefore you have a double attack there, where not only does the nutrition suffer, but the hormone that produces hemoglobin within the body reduces in levels because of chronic kidney disease, and that leads to anemia. Now, anemia can cause several things. It can cause lethargy, it can cause weakness, it can affect the heart, it can affect the brain. The heart can go into a cardiac failure because there's not enough blood around, or the strength of the blood is reduced. So you can develop leg swelling from heart failure. You can develop breathlessness from heart failure. You cannot really walk a long distance. Your exercise tolerance, or your tolerance of day-to-day work, such as climbing stairs, or let us say going from the bedroom to the toilet, all this suffers. And if that happens, the patient really suffers from a symptomatic point of view. In such a situation, you would want the hemoglobin level to be at a decent level. Normal hemoglobin levels are between 14 to 15. 13 is acceptable for females as well. However, in patients with chronic kidney disease, to 8, and this is pretty bad for these patients. In such a situation, we would want to make sure that the hemoglobin level is not dropping, and in such situations, for those who can afford. We would obviously advise them to take intravenous iron treatment as well as erythropoietin injections to keep the hemoglobin at a target level of about 11 to 11.5, no higher than 11 to 11.5, and that will definitely help improve many of these symptoms that I just described.
That's very helpful, Dr. Kanchi. Thank you so much. Moving on to serum creatinine and blood urea, some people argue that somebody who's on dialysis for a couple of years now, what value does creatinine and urea actually add? If you can just throw some light on that, that would be very useful, Dr. Kanchi.
So with respect to blood urea and serum creatinine, these are two of the toxins that we know are removed on dialysis. And basically, these are the toxins that are measurable in a lab in a cheap manner. And as a result, these are the tests we use to measure the adequacy of dialysis, the amount of toxins that are removed. Remember, chronic kidney disease leads to a humongous amount of toxin accumulation in the blood. All this is now going to be removed on dialysis, at least part of it during every dialysis. And therefore, we need to have a sort of a rough estimate on how good the dialysis is. We call this dialysis adequacy. Is the treatment that we are giving to every patient of chronic kidney disease, is it adequate? One of the ways of measuring it is by checking the serum creatinine and blood urea levels. Obviously, to the patient, it appears that the serum creatinine has gone up to 8 or 9. We start dialysis, and then when they check it again, the serum creatinine is still 6 or 7. And the first thing they come and ask me is, Doctor, the dialysis is of no use. The creatinine is still 6 or 7. And the answer to that question is that the best treatment for kidney failure is kidney transplantation. I think we all know this. Right. Kidney transplantation will bring that creatinine down to 1.0, down to normal levels. Whereas hemodialysis does not bring it to normal, but it does reduce the serum creatinine and blood urea to significant levels. This was what I was talking about with urea reduction ratios. You're talking about a removal of a toxin of about 70% at the end of dialysis. So we are trying to remove urea, and the urea removal will be roughly about 65 to 70%. The creatinine removal will be roughly about 50 to 55% for every dialysis, which means that if a patient comes with a creatinine of 10 at the start of dialysis, his creatinine is going to go down to 5 at the end of dialysis. Not going to go down to 1. It's going to come down with 4 hours of dialysis. It's going to come down to about 5.0. But the very next day, the body is already churning and creating these toxins. So these toxins will accumulate again. So to put it short, urea and creatinine are those two toxins that we check regularly in the blood to make sure they are not going out of bounds, and to look at the adequacy of dialysis by measuring urea reduction ratio and KT over V, which are the formulae that give us how good the dialysis we are doing in each patient is. So this is the reason why we do creatinine urea values, and the reason why the values don't go down by much is because they keep accumulating, because the body is churning, digesting, metabolizing, and these metabolites are being created every hour, every minute, every second. And therefore, it's a regeneration versus removal, and therefore we need to know that.
Okay, no, that's very helpful. You touched upon a little about the nutrition part where you covered sodium, potassium, and albumin. If you can just give a little more information on that briefly, then we can move on to the next part of the talk, Doctor.
So quite important to maintain your electrolytes in normal limits. Usually the sodium level does not change much. Sodium levels maintains between 135 to 140, 132 to 140, depending on the calibrations of the machines. And that's usually not an issue for most of our dialysis patients. Sodium is important, on the other hand, as a salt. If you do take a lot of salt in your diet, your blood pressure is going to go up. You're going to retain a lot of water. We're going to have to remove a lot more water on dialysis, and that's going to stress your heart and brain. It's going to stress your lungs when you come in for dialysis, because you may be breathless already. And it is going to stress your heart, and because the overload means extra water in the body means that the heart has to work more, and heart failure can happen because it is stressed and cannot work more, and that will lead to more water accumulation. So sodium is one aspect. Potassium is another important ion electrolyte in the body. Potassium can accumulate in dialysis patients because potassium is actually excreted by the kidney by its tubular function. The kidney is no longer working. All the potassium that you taken in your food now accumulates in the body. And the problem with potassium is if you develop hyperkalemia, a high potassium level beyond 6.57, you are going to develop problems in the sense that potassium is going to affect your muscles and cause muscle weakness. You may develop some form of flaccidity or weakness in your muscles. You may be unable to stand up, and that can cause problems. But the more important thing with potassium is that it can affect the heart. It can actually make your heart go into a standstill in diastole. The heart relaxes, the potassium relaxes it more, and it stops beating. So the heart can actually slow down when your potassium goes above 6.5. Your heart rate can slow down from a normal of 70 to 80, right down to 60, 50, 40, and your heart can come to a standstill if your potassium goes above 7.5. So it's very important to keep the potassium within limits, and the dialysis is able to do that. And because we need to make sure that the patient is hopefully sticking to a sort of a diet that we've prescribed to the patient, we keep watching the potassium, make sure it doesn't go out of bounds, and therefore the check on the sodium and potassium. With respect to albumin, this is quite an important blood test, because one of the most important predictors of poor outcomes in dialysis patients, as well as mortality, is serum albumin. It is, in fact, the strongest predictor of, let us say, morbidity, admissions to a hospital, mortality, death in patients on dialysis. The lower your serum albumin is, the higher the chance of death. So this is a very important nutritional factor that tells us, look, you have to keep this at a level that is above 3.5. Normal range is between 3.5 to 4.5 grams. You're looking at anywhere between 3.5 to 4 grams is somewhere you want to keep this serum albumin at. And the best way to do that is to consume proteins in the form of dal, egg white, and dairy products to some extent, definitely meat and meat products. So these are high in protein, and these are the sort of food that you should take to improve your protein levels, especially the serum albumin level. And the lower the albumin level is, as this graph shows, the higher is the mortality. So we need those serum albumin levels between 3.5 to 4, and that is something that we advise most of our dialysis patients to take extra protein in their diet. Back to you, Kamal.
Yeah, great, Dr. Canchi. That's very helpful. Moving on to virology, Dr. Canchi, I think there is some resistance on patients like me, our part, that why should we do virology? Because now, for example, for hepatitis C or hepatitis C, there is a treatment, but hepatitis B, I mean, there is no, there might be some treatment, but typically offered, not very high rate of success. So if I'm not going to treat it, why should I even bother finding out? Or hepatitis C, I'm not, it doesn't affect me. I don't have any symptoms. Why should I bother? So could you just tell us why doctors and dialysis centers require virology, and what is the frequency, and some light on that? Very useful.
Yes, of course. So virology is quite important. Some hospitals, or many of them, do once in 2 months, once in 3 months. This is the sort of frequency with which we do these virology tests, HBsAg, HCV, and HIV. Some hospitals, many of them, or most hospitals, will definitely check the virology of a patient when he or she is first admitted into a dialysis unit. We want to make sure that this patient is negative on all three aspects. Now let's take HCV and talk a bit about that. The hepatitis C virus is a virus that can affect the liver. Now, HCV is commonly seen in dialysis units. If you look at, let us say, high-income countries, you still have about a rate of between 1% to 6% as far as high-income countries go. We in the middle income and low income countries have a higher rate of hepatitis C in our dialysis units, anywhere between 3 to 15% or more. Some units have quoted up to 20 to 30%. So yes, HCV is a problem in dialysis units. Now, the at-risk people who can actually get hepatitis C are obviously drug users, sexual workers, but dialysis patients are at risk because there is an in-house unit, a unit that has HCV patients, and this can get transmitted. Blood transfusions initially were a problem. Now with proper screening, blood transfusions are much less of a problem as far as transmission of HCV goes. No, the problem with HCV is, yes, many patients who actually get infected with HCV may not have any symptoms at all. But when HCV is there inside the body, it can cause two problems. Slowly, it can eat away at your liver without causing symptoms initially. And finally, that patient can end up with a very major illness called cirrhosis of the liver. Now, this cirrhosis of the liver is quite a bad problem, and the longevity of the patient is reduced. The mortality of the patient is increased when yet another organ failure occurs apart from kidney failure. So that is one aspect. The second aspect of it is this HCV can also cause cancer within the liver. So this is something that you need to be aware of. And therefore, while I understand the fact that some of these tests can cost a bit, we would advise many of our patients to do these tests. If you're looking at HBsAg, this is now much less of a problem, or the hepatitis B virus, basically because immunization is available. You have the vaccine for HBsAg virus, the hepatitis B virus. Vaccines need to be taken. Every patient has to make sure that they've taken their vaccines in proper doses. The anti-HBs, which measures the vaccine efficacy, should be looked at, basically because only 50 to 60% of dialysis patients respond well to 4 doses of vaccine, 0, 1, 2, and 6 months. Double the dose, 40 microgram, 20 microgram is the usual dose, and it should be given into the deltoid, not into the gluteus, that is, not into the buttock area. It should be given in the arm area. So again, the HBV virus, when you develop an infection, it may be, very sort of asymptomatic in certain individuals. Many may not have any jaundice at all. Some may. Again, this is another virus that, if left untreated, can again proceed to cause liver cirrhosis. It can also cause liver cancer, hepatocellular cancer. So it is very important for us to check this once in 2 to 3 months to make sure that you are not becoming positive from this virus. There are other tests, including the liver function test, that could point to this, but we'll come to that as and when Kamal asks me that question. Back to you, Kamal.
Yeah, no, we can actually go to that. So what I've heard, Dr. Canchi, is that the hepatitis C, hepatitis B tests, sometimes, even after a few weeks of being infected, the regular antibody or antigen tests don't actually throw up positive. So are there any more accurate or more reliable tests that can tell us if we've been infected within like maybe a day or two of being infected?
Let me go back to the LFT first. The liver function test is an important test that we tend to do once in 2 to 3 months. Actually, the liver function test is important, basically because you can pick up some small shifts in your SGOT, SGPT, also known as ALT, AST. because of pyridoxine deficiency or a pyridoxal phosphate, an enzyme deficiency, actually in patients who have their LFTs done, will know that their SGOT, SGPT levels are actually in the low limits of normal. It can be 5 or 10, and even a shift from 5 or 10, the normal being right up to 40 or 50, even a shift from 5 or 10 to a level of 30 or 40 within the normal range, a change may give you some idea that, look, something is happening in the liver. And this may be a pointer to actually getting your HbSAg and anti-HCV done. Now, both these tests are good, but there are better tests available nowadays, and these are the NAT tests, or nuclear acid testing, which is also called the RT-PCR. These tests actually help uh, diagnose these infections faster, earlier, and you can start treatment earlier with this. But these tests are pretty costly compared to the LFT and HbSAg, HCV. So therefore, not many units do it. There is also, as far as HCV goes, a 17% chance of it being negative as a false negative, even when you have a HCV in your body. In such a situation, it's up to the nephrologist then to look at your numbers, or perhaps the gastroenterologist whom the nephrologist refers to look at your numbers and say, look, I am seeing some difference in your bilirubin or SGOT, SGPT levels, but I'm not quite seeing the HCV to be positive. However, I would like a nucleic acid testing or an RT-PCR of your HCV, or a HCV RNA test, which will tell me whether you're infected or not. There are two types of RNA testing. One is a qualitative testing, which is cheaper, will tell you whether you are infected with the virus, the HCV virus, or not. The other is the quantitative, which will give you the species of the virus as well as the number, the log number, which will tell you how many viruses or what is the virus load in your body, and therefore should this be treated or not. So that information you can get from a HCV quantitative. From the hepatitis B virus point of view, you can check the HBV DNA, which is also an RT-PCR, which will also give you the same sort of information that the RNA HCV gives, which is, again, the load of the virus, the positivity at an earlier time, and therefore the need to treat that virus with oral medication. Both of these viruses can now be treated with oral medication. Yes, back to you, Kamal.
Okay, yeah, no, that's very helpful. COVID being the flavor of the year, Doctor, I wanted to touch upon a little bit about COVID. So currently, what are the protocols for COVID for dialysis patients? Like, what tests do dialysis patients need to undergo with relation to COVID specifically?
So quite frankly, when the COVID was at a high, we did lose quite a number of patients to COVID. And RAT testing and RT-PCR, these are the two that we have, obviously. And most of you now, most patients, most of the general population, everybody knows about this, that the RAT testing is the initial test that can be done. It is cheaper, but there is a 40 to 50% chance of a false negative cropping up with the rapid antigen testing. And therefore, you would want to do an RT-PCR, which is the better form of testing. An RT-PCR involves swabbing the nasopharynx, the passage in your nose, just beyond your nose, as well as the mouth. Some people tend to go for the test and try to get only their mouth or their pharynx swabbed. But that is a fallacy. That is wrong. That's basically because when you do the swabbing from your nose, it is a bit, a bit uncomfortable, the swab going through your nose, and I'm sure many people don't want it. But the better way of testing RT-PCR is through your nose into the cavity just beyond your nose, because that's where the virus hides, and that's where the RT-PCR can pick up maximum positivity. So I guess for COVID testing, you would want to do an RT-PCR to look at that and then take a call on how to treat that.
And what about antibodies, Dr. Kanchi? Like there is a lot of talk about dialysis patients, some dialysis patients not developing antibodies, the antibodies waning in a short amount of time. I myself, I've checked antibodies and I have zero antibodies after, a few months of the second dose of the vaccine. So what are your thoughts on should dialysis patients get their antibodies tested? If so, how often or how long after the second dose of the vaccine?
So this is an excellent question, and not many of us have the right answer. We still, I would say, generally speaking, don't have the right answer, and that's basically because we're still learning. It's learning on the go actually during this pandemic. And some of the first data that came to us was from the US and Europe, and they were looking at this vaccine data and found that in dialysis patients, the response for the first dose was a bit low, between 18 and 41%. As you can see in this tweet from Dr. Swapnil Hiremat, who is in Canada and watching over these events. But it does improve with 2 doses. And even in dialysis patients, you can get a range of cover of up to about 80 to 96%, of antibody production. But the question then arises, is antibody production the main thing? And therefore, and much of this, I looked at the NEFJC website that covers COVID vaccine. They give us really excellent info on this. The question is, we are actually relying on a surrogate outcome. The surrogate outcome here is the antibody, the spike antibody, or whatever you call it. The response to the vaccine is usually measured by a spike IgG antibody, and those are the levels that the lab reports, and those are the numbers that you see and decide, oh, the vaccine is protecting me or not. But generally speaking, this is a surrogate marker. This is a marker that says, look, the vaccine has given this response, and I believe that this response protects me from the infection. The better way of looking at it is to look at what happens in real life. And you have a paper from our moderator here, Mr. Kamal Shah, and his team. They came out with this data, which said that individuals who have received even 1 dose of the vaccine had a 33% reduced risk of being infected with the virus and a 46% lower mortality. This is quite humongous, and this is very important that this data has come out, where even 1 dose of the vaccine brings such protection to dialysis patients. So on the one hand, you are looking at antibodies from a vaccine. This is a surrogate marker that hopefully tells you that you are protected. But the best way is when you take both the vaccines and go out. You're going to do that because you're going to go to the hospital 2 or 3 times a week to do dialysis.
Right.
And therefore, the protection that the vaccine offers has been measured in this trial. And there are more studies that have come out with these data. So yes, measuring your antibody levels is probably the way to go, but the jury is still out. We don't have the data yet to make this strong statement saying that go out, measure your antibody levels. What do you do after that? The government of India has still not proposed a booster dose or a 3rd dose.
Right.
There are people in the UK, in the US, who are already onto this booster dose, mixing of vaccines and so on. Right. Yes, they have the wherewithal to do it. Here, we are still looking at protecting the general population, and our population is huge. And we are still aiming all our vaccines at the 1st and 2nd dose. So generally speaking, therefore, the government will still be on its back foot as far as the 3rd dose goes. So I would put it this way, definitely take the first 2 doses of the vaccine. That is very important for you to protect yourself. You may want to check your antibody levels, but you may not be able to do much beyond that. But rest assured that whatever vaccines you have taken are actually protecting you already from the virus. That is how I would look at that.
No, that's very reassuring, Dr. Kanchi. Thank you so much. We take a few questions now, Dr. Kanchi, if you permit me. There are some questions that have been taken by the Kidney Warriors Foundation when we announced this session. So I'm going to go through some of those questions. Have read that chronic low flux dialysis causes an accumulation of middle molecules over time. This can cause many problems. I want to know if and what tests do we need to do for these middle molecules and any solutions for this other than using high flux.
So this has to do with high flux and low flux. Okay. Now, as far as dialysis goes, most of what we do is low flux dialysis. Obviously, high flux is rarely used. There are a few centers who do hemodiafiltration, which is a different form of dialysis that I'm not going to go into. What I will say is middle molecules or large molecules, the smaller molecules are easily removed on dialysis. The larger molecules are not. Some of the larger molecules are the so-called middle molecules. This could be anywhere between 1,000, 15,000, right up to about 56 to 60,000 Dalton. Those are the molecular weights we're speaking of. And in this category, when you go to 65,000, you're looking or you're staring at serum albumin. You don't want you to lose albumin. So you got to be careful. So there were a series of dialyzers prepared called high cutoff dialyzers, HCOs they were called. And we were trying to use them in multiple myeloma, trying to remove the myeloma protein to see if the patient benefits from it and to see if the mortality improved. There were a few trials that showed yes, there were many that showed no, it wasn't. And so you then moved on to what was called middle cutoff or medium cutoff dialysis or MCOs. These are still undergoing trials in Australia and New Zealand where you have middle molecule removal and they have shown that middle molecules can be removed. The middle molecules are basically cytokines, a host of them, including IL-6 that has come into fashion after the COVID infection, adipokines, inflammatory markers, TNF alpha. These are all new terms for our dialysis patients, but I'm just throwing them up so that you can go and read about it. But these are molecules that we generally don't look at in our tests. And quite frankly, therefore, little experience with it. And for that matter, if you're looking at middle molecules, some of the middle molecules are removed if you lengthen the session of dialysis. 4 to 5 hours of dialysis can remove some of the middle molecules. So that is something that you should know. So yes, middle molecule removal is undergoing trials. They've just come out, I think, with the result in a set of about 80 patients in Australia and New Zealand in 2020. So we are still looking at that with interest, but I would not, I cannot recommend middle molecule removal dialyzers at the moment. High flux dialysis actually removes only the beginning of these middle molecules. There are a whole host of them, and you don't want to go into the high cutoff area because that removes albumin as well. And they've tested and found that albumin about 3 to 3.5 grams is removed every dialysis, which is a humongous problem. Remember, I've already told you people that serum albumin is the single most important marker for morbidity and mortality. So you don't want that removed from the body. Yes. So obviously that's why people have moved to medium cutoff and so on, still undergoing trials, still not available for the common man. But if it does come up, we'll have a look at it and decide on whether we can use that.
Right. We've talked a lot about blood tests, Dr. Canchi. There is a question that has come about fistulograms, Dopplers. How often are these needed by dialysis patients? Is it something that needs to be done particular frequency or only when there is some issue? What are your thoughts on that?
So this is a question that each nephrologist or each unit may address differently. There are certain units, especially in the West, that do fistulograms every 3 months to 6 months just to look at what's happening to that, what are the flows, is there a problem, and so on. From the Indian dialysis center point of view, most of us are reactionary. We react to problems. We are unfortunately not prophylactic. Therefore, if a patient has a problem and the problem is usually reported by the dialysis technician, there is a flow issue with this fistula, there is a high venous pressure alarm that is sounding. The venous pressure used to be 90 to 100. and now the venous pressure is 130 to 140. These are warning signals that tell us there's something happening with the AVF, and we then say, okay, get a Doppler done, let's look at the flows, get a fistulogram, and so on. But I tend to agree, maybe there is a scope for looking at sonographic monitoring of these fistula once in 3 to 6 months, just to make sure that we are not straying into that area where a problem is actually forming and you're not looking at that formative area of the problem. You're only reacting to a problem that has already been created, which is always a bit of an issue. The issue obviously then is you have to spend more. Every patient who goes to a Doppler or a fistulogram has to spend that money to make sure that the AVF is working. If it's working fine, then you may come back and crib. Array, this is a waste of a test. Why did I have to spend all this? The fistula is working fine already. So these are issues that we as nephrologists do face. So it's a bit of, a situation where we have to find a balance, and that's always difficult to find. I must mention that apart from this fistulogram and stuff, I would look at doing an ECG, echocardiogram, and chest X-ray in every patient once in 6 months to a year. This is very important for patients who are on the transplant list. Often the patient is somewhere else doing dialysis somewhere. He's on your list, but he's gone to some other unit. He's still on your list because when the transplant comes up, the call for transplant comes up, I pick up the phone in the dead of the night, and I have no idea if this patient has undergone an echo and he's going to come back in the dead of the night, and I'm not going to be able to get these scans done. So all patients who are on the transplant list have a different set of investigations, including an echocardiogram, ECG, a treadmill, or even another sort of stress testing called dobutamine stress, and angio perhaps for those who are diabetics. These are things that your nephrologist will tell you to do on a yearly basis, perhaps a 6 monthly basis, depending on the extent of the problem that the nephrologist is able to diagnose. Back to you, Kamal.
Yeah. There is a question on Cystatin C test. I've seen a lot of chatter on Twitter recently on Cystatin C. It's found its way into this session as well. I'm not sure. Is it also used in early stages of CKD? Tell us a little about this test as a comparison with serum creatinine.
If I'd known that this question was going to be asked, I'd have put up some of my own tweets that I've tweeted out during the past 3 days. In fact,
I saw your survey and the creatinine versus cystatin. Yeah,
absolutely. And if you look at the survey that I put out, though it was a small response, 90% of patients are still in. A very small number is doing cystatin C. Cystatin C is costlier. Doing a creatinine may be between 75 to 150 rupees. Doing a cystatin C test it is anywhere between 1,100 to 1,300 rupees currently. Cystatin C is a molecule that will give you, in certain situations, a look at your kidney function. Creatinine is a test that depends on the muscle mass of a patient. So if you have a patient, not necessarily a patient, if you have a person in the general population who's a bodybuilder, doing bodybuilding, taking a lot of protein powders, and he comes to you with a creatinine of 1.5, you're now wondering, is this patient having kidney failure, or is the muscle mass so extreme in his body that the creatinine, the kidney is actually working well? The kidney probably, and this is something again I've tweeted out yesterday, the kidney is probably working better because there are studies that show after a high protein meal, the GFR of a normal kidney actually increases.
Oh, is that
from
right?
120 to 140, or maybe more, to clear the creatinine. So you are looking at a patient, even though the creatinine is high, it's because of the muscle mass. So in these situations, to look at whether that patient has a kidney problem or not, cystatin C can be used to measure the GFR and tell you that, oh, look, the GFR is fine. Because if you use the creatinine in the equation, the GFR will definitely be less, because creatinine is a very important factor in that equation. Similarly, if you have a very lean individual, a cachectic individual, who doesn't have any muscle mass, you're now looking at a creatinine of 0.9 to 1, that may still be an abnormal creatinine for that individual. So in such a situation, again, cystatin may be useful. So there are certain situations where cystatin is useful. At some point in time, hopefully this will, become more popular and replace creatinine. Not yet. At present, we are still using creatinine to look at kidney function.
Right, right. There is a question on serum potassium, Dr. Canchi, where I think there are several cases where the potassium result comes out, extremely high or very difficult to believe kind of results, where the patient is fully normal, they are walking, but their potassium comes out 6, 7, 7.5, and so on. So the question that has been asked is, what can we do to, and we've been told that by labs and so on, that it's a very fragile kind of a test where any disturbance or any problem with the sample, it kind of can mess up the result. So what precautions can patients take, or centers you would recommend they take to ensure that the potassium test comes out right?
So this is basically perhaps due to lysis of RBCs when the blood test is done. So whenever you do a blood test, if you tie the tourniquet too tightly across the arm and then try to, give me a moment, please.
Sure.
Rupa, answer this phone. You tie it too tightly, and therefore there is a lysis of the RBC, giving rise to a spurious increase in the potassium level, and that is usually the cause for a high potassium, which can be mitigated by, again, not being too tight about your tourniquet and finding a vein. This is always very difficult. Finding a vein that where you don't have to really be very tight about the tourniquet and still be able to withdraw blood. There is another look at this, and the other look at this is that patients with a high potassium of 6 to 6.5 may still have no symptoms at all. So, and that is because their intracellular potassium is also high. So you need to be careful in those patients.
Right.
So I would say, yes, you need to be careful, but one of the reasons is lysis.
Sure. No, that makes a lot of sense. There's a question on COVID specific investigations. Any specific investigations do we need to do post-COVID recovery, let's say 3, 6, 9, or 12 months down the line? Anybody who's recovered from COVID, is there any?
Yeah, well, this is a difficult question to answer. Some of them may develop fibrosis in their lungs. Oxygenation can be an issue, and therefore in such patients, CTs or X-rays or a pulmonologist opinion may be important. You would want to look at a higher clotting problem in these individuals. So you would want to look at clotting as a problem, and therefore be very careful with that.
Okay. I hope that answered the question. I think we're almost at the end of the session, Dr. Canchi. We have about 5 minutes left. So I hope you'll forgive me. I'm going to put you in the spot here. And I'm going to say, let's say you have a patient who is you cannot afford the entire gamut of tests, right? Which tests would you say they need to do every month, every quarter, every 6 months, every year? Like, you would sincerely tell them that find the money, but get these tests done. Like, what would be the minimum tests you would recommend?
So I would
6 months and 12 months.
1 month would be HB, creatinine, sodium, and potassium.
Let me just repeat that, Dr. Canchi, for the benefit of everybody. So Dr. Canchi says every month HB, sodium, potassium, creatinine, and urea. These tests, absolutely, please get it done every month. Every 3 months, Dr. Canchi?
Every 3 months, I'd look at calcium phosphate and LFT, as well as the viral markers, HPCAG, HCV. At 6 months, I would look at PTH and nothing much, quite frankly.
Okay.
At 1 year, I'd look at ECG, echoes, and chest X-ray.
ECG, echo, and chest X-ray every year.
Yep.
Every 3
especially
months.
For those who are on the transplant list. Yeah.
Sorry?
Especially those who are on the transplant list, and even otherwise, I would want their heart checked every year.
Right. Echo, ECG, and you said,
X-ray.
What was the third thing you said, Dr. Canchi?
Chest X-ray, ECG, and echo.
Right. Chest X-ray, ECG, echo every year. Every 3 months was calcium, phosphorus, viral markers, LFT. and 6 months you said PTH and nothing else apart from that. But so I hope we've answered your questions, dear viewers. And Dr. Canchi, any parting words for patients on this contentious topic of investigations? I think the main concern, Dr. Canchi, I'm sure you appreciate, is that where in a country like India, where a lot of patients are not able to afford even their dialysis. Of course, you said about 55% of your patients are already on some form of like insurance or government insurance and so on. 45% is still quite a large number where they have to pay. And I'm sure this number varies from center to center. But where patients are finding it difficult to pay for their dialysis, I'm sure you appreciate that this investigations is a contentious topic, apart from their medications, EPO and iron and so on. So any parting words on what you would advise as a nephrologist to us patients on this topic?
Kishan. Well, I would just say that we should, look at doing minimalistic tests for most patients, especially those who are unable to afford, and not look at this renal packages, which can be a problem for most patients. So we'll have to look at avoiding that as an important sort of. I mean, you have to look at the economics of the patient before you prescribe tests. And to some extent, minimalistic tests means you're only going to spend about 300 to 500 rupees more. But if you're forced to spend, let us say, 2,000 to 3,000 because you're doing the packages, you may want to cut back on that. And therefore, the patient will then be in a more relaxed sort of posture to do those tests rather than not. That's all I will say.
No, thank you so much, Dr. Canchi, for this very enlightening interview. I myself learned so much from you, and I really appreciate you spending the time on educating us patients about this important topic. And I'd like to, on the behalf of NephroPlus, thank Vasundhara Raghavan, who's been doing such an amazing job with the Kidney Warriors Foundation, organizing these webinars. And she herself is such a fantastic lady with an amazing life story. I think she's an inspiration to all of us on the way she's handled her life, her son's transplant, and so on. So on behalf of NephroPlus, I'd like to thank the Kidney Warriors Foundation and especially Vasundhara Raghavan for the fantastic job you all have been doing. And thank you for partnering with NephroPlus. We are also extremely delighted to be working and educating dialysis patients and kidney disease patients across the country and beyond. And we hope to continue this partnership to bring you more such webinars, more such interviews. Please let us know in the comments what topics you would like us to cover, and we will definitely try to cover these topics in the coming sessions. Thank you so much. Thank you, Vasundhara. Thank you, Dr. Canchi. And here's Kamal Disha, co-founder of NephroPlus, signing off on behalf of all of us. Thank you all. Have a great evening.
Thank you. Bye-bye.